Uh, Greetings, everybody, to today's BRISE webinar on experiences of sexual health care among recently arrived gay and bisexual men. You were probably expecting to see Dr. Ben Babington from the Kirby. He's unfortunately been called away today and asked me to step in to chair. My name is Andrew Grulich and I lead the HIV Epidemiology and Prevention Program at the Kirby Institute at UNSW. And of course, before we start, I want to acknowledge that we're all coming from unceded lands of our Indigenous peoples, and I'm coming to you from the lands of the Gadigal people of the Eora Nation, and pay my respects to their elders past, present and emerging, and also extend that respect to any Aboriginal or Torres Strait Islander people who might be joining us today. So we have a topical webinar topic today on sexual health care among recently arrived gay and bisexual men. Just a quick description of the format. We've got one main presenter today, Dr. Nathaniel Wells, who will give a presentation for about 20 minutes. And we then have a couple of respondents who I'll introduce after the presentation. And then if the timing is working for us, we should have about 15 minutes for audience and Q&A. So with that, let's make a start. Our first presenter, or our main presenter today, is Dr. Nathaniel Wells, whose pronouns are he, him. Nathaniel is a research associate at the Kirby Institute at the University of New South Wales. Nathaniel, over to you.
Thanks, Andrew, and I'll just share my screen. All right. I'm assuming that's working.
Yep, all good.
Perfect. So hi, everyone, and thanks for the opportunity to present and share some of this work with you today. As Andrew just said, my name's Nathaniel Wells, and I'm a research associate at the Kirby Institute, UNSW. And today I'm going to be presenting some data and findings from a project that explores how recently arrived overseas-born gay, bisexual and other men who have sex with men connect and engage with sexual healthcare services and or LGBTQ+ communities after arriving in Australia. So I to acknowledge the traditional custodians of the various lands on which many of us are dialing in from today. I'm speaking from the unceded lands of the Wurundjeri Woiwurrung people of the Kulin Nation, and pay my respects to elders past and present, and extend that respect to any First Nations people who are joining this webinar. And I think in the context of migration as well, I also wanted to acknowledge the ongoing processes of colonisation that are continuing to shape health inequities today, particularly around HIV and STI epidemics, both here in Australia and globally. So just as some brief background, we know that overseas-born gay, bisexual and other men who have sex with men, or GBM, account for an increasing proportion of new HIV diagnoses and are a priority population in the New South Wales HIV response. Previous research has found individual-level barriers to engaging overseas-born GBM in care, including anticipated stigma, internalised homophobia and HIV-related stigma. But it's also really important to acknowledge structural barriers, including Medicare ineligibility, limitations on working hours for international students, and policies that automatically deny migration for people living with HIV. Despite these barriers, some overseas-born GBM do engage with sexual healthcare services, although little is known about the pathways through which these connections are made. And so for this study, we deliberately recruited participants who had so-called successfully connected to sexual health services and or LGBTQ+ networks. And we didn't necessarily preclude those who hadn't, but our aim was to understand how and why connections were made. And so I think it's important, that's an important framing for this, just to acknowledge that the accounts I'll be presenting shortly shouldn't be read necessarily as representative of all overseas-born GBM. But in this presentation, I'll be exploring the journey from discovery of sexual health services in Australia to first contact. So briefly, interviews were conducted with GBM who were born in Asia, Latin America, Africa, the Middle East, or Eastern Europe, who lived in New South Wales and had arrived on or after 1st of January 2017, identified as GBM and were 18 years or older. And the interviews explored a really broad range of topics, including how and why participants first connected to sexual health services, experience of these services here and in their countries of birth, migration experience, HIV prevention strategies, involvement with LGBTQ+ communities, and experiences of discrimination in healthcare and community settings. Just to quickly go through some demographics. So we interviewed 29 participants and most were within the 20 to 29 age bracket, which was unsurprising given that almost 2/3 of participants had arrived on a student visa. Most identified as gay male, most were born in the Asia or Latin America regions, most were HIV negative, and 5 participants were living with HIV. And just as a caveat before I present some of the findings, I'll be referring throughout to broad geographic regions and not individual countries. And while this does risk homogenizing entire regions and overlooks important nuances within them, I've done this just to minimize the unlikely possibility of any participants being identified. So onto the findings. Participants described a really broad range of ways of learning about and first connecting with sexual health services. So many found services just by searching online. For others, learning about sexual health services occurred almost through being in the right place at the right time. So one participant saw ACON's Ending HIV campaign at a train station that prompted him to go onto the website. Another saw an advertisement for free testing, as he was walking past a test on Oxford Street. One participant who had a history of testing every 6 months before coming to Australia first connected to sexual health services through having an STI test at one of Sydney's sex on premises venues. So he recalled, I found it first by going to the sauna. They do some screening there sometimes. I think they don't do bloods, they only do a pee test. Then I followed that up with a full screening. So saunas and sex on premises venues, along with apps like Grindr, were the most common avenues through which participants met sexual partners, and in some cases even developed social connections with other GBM. And I think it's entirely possible and extremely likely that this particular participant would have sought out HIV testing regardless of doing an STI test at the sauna. But it was this experience that ultimately prompted him to search online for an HIV testing service soon after he'd arrived. I think many of us will know the disruption, migration, and adjusting to life in a new city might cause to existing routines, including routines of healthcare seeking. But at the same time, moving to a new city or country opens up a new Grindr grid and also presents new and exciting sexual opportunities, which are probably more enticing to engage in when compared with going for an STI checkup. And so for me, I think this example highlights the ongoing value and importance of having HIV and STI programs or resources about them in contexts like these where individuals are looking for sexual partners. Universities also, and university health services also played a really important role in connecting participants to health clinics. One participant described that it was through his university's O Week events that he first became aware of sexual health care, both as a concept generally as well as about clinics specifically. So this particular participant had grown up in a country where he said that there was virtually no sexual health education or information, let alone LGBTQ+ health information. Indeed, he commented that despite his mother working as a healthcare professional, he was actually unaware of any STIs other than HIV before coming to Australia. And reflecting on how he first became aware of sexual health services, he stated, I came across ACON because at university, on the orientation day, they give you heaps of goodies and stuff. They provided information on what STIs are and everything. I Googled, and that's how I came across ACON. So when I asked him what the experience of getting all this information was like, particularly given the context from where he'd arrived from, and the fact that he'd only been in the country for a few weeks, he described an initial sense of confusion. But after a short period, he sought out more information and actually went for an HIV and STI test. And he also described the information he received as mainly targeted towards heterosexuals, and it wasn't LGBTQ+ specific. But even that limited information was enough to prompt him to go and do his own research online. For several participants, first connecting to sexual health services occurred because a partner or a friend had told them about a recent STI diagnosis. One participant commenting, I had sex with someone and they were kind enough to inform me that they had contracted syphilis and I should probably get tested and checked. So this participant hadn't ever had an HIV or STI test prior to this and was directed to a sexual health clinic by his university GP. And I just to pick up on the word kind in this quote here, A couple of participants made a point to comment on partner notification and even discussion of sexual health in general as something that seemed to be quite normalised in Australia and something that could be done without shame, judgment or stigma. Now, obviously, this is always the case. Australia isn't some STI utopia where partner notification is always met with appreciation. But I think it points to the role that sexual norms and cultures can and do play in engaging people in care and promoting sexual health. And in the era of PrEP and U equals U, I think it's important to acknowledge that a new norm has almost emerged where discussion of HIV prevention strategies prior to sex is less and less common. On one level, I think it's absolutely worth celebrating the potential of biomedical prevention to remove anxieties about HIV transmission from sex, both for people living with HIV and those who aren't. But sexual networks have played a crucial role in fostering HIV prevention behaviours, particularly condom use, throughout the history of HIV in Australia. And I think we also saw that in the early days of PrEP rollout as well. And at the risk of suggesting sexual encounters should also be educational, I think it raises an important question of what might be lost through the negotiation of HIV prevention not occurring, particularly for those that may arrive from countries and contexts where information about HIV prevention and PrEP may be more limited. Social networks as well played a really important role in facilitating connection to sexual health services, the sharing of health-related information, and in helping participants adjust to sexual health norms here in Australia. For some, the shared migration experience and or shared cultural background was also really important. As this participant commented, you don't grow up here, you don't have that reference. I do trust that someone like me in similar conditions can recommend something. I'll probably trust them more. It's just about trusting someone that is like you. So it wasn't that this participant necessarily distrusted those who were born in Australia, but that shared experience of migration and or cultural background provided a greater sense of understanding the needs of others who had also recently arrived in a way that Australian-born GBM couldn't do. And that was even in some cases Australian-born GBM whose parents had migration experience from the same cultural context or country. Beyond the shared migration experience, participants also spoke of how friends or even friends of friends were the connection point to organisations like ACON, and from there, connection to sexual health services. Involvement with community-based organisations such as Tricone and others were also characterised by some participants as important and culturally safe avenues for connecting them with broader LGBTQ+ networks. And I think it's important to emphasise that there are already really well-established LGBTQ+ networks organised around different cultural and religious groups, and to perhaps consider the role that they might have in disseminating information about sexual health care. And I'm sure Locke could speak to some of the successes and possible challenges in building relationships with, say, the organisers of Western Sydney's Westfall, just as one example. But I think it's also important to acknowledge that for some individuals, connecting to LGBTQ+ networks isn't always a priority for a multitude of reasons. So one participant who was here on a student visa hadn't really engaged with Sydney's LGBTQ+ communities just because studying was his priority and he really just didn't have time. But he was involved in multiple student associations and clubs through his university, where he was also quite open about his sexuality. So he wasn't distancing himself from those communities. Another participant described being more connected to the diasporic community from his home country. And he said, I think it just makes it easier when you're moving in the first place anyway, because you don't know anyone and then people from my home country are already here and probably they can help me. So most participants actually really valued being connected to broader LGBTQ+ networks. And even these two participants weren't against having other LGBTQ+ individuals in their social circles, but they were just a bit more, I guess, ambivalent about the importance. And although these two participants weren't connected to LGBTQ+ networks, this didn't mean they were necessarily unconnected. And so I think what these two examples encourage us to do is, in the first instance, to question what we might even mean by unconnected, but also to consider what other networks beyond LGBTQ+ networks could be leveraged in the promotion of sexual health services. So far, I've presented accounts of ways in which participants connected to care. However, some participants also reflected on some barriers to access. So some described a degree of uncertainty about what to expect from health services, including being unsure that they were or being unaware that publicly funded sexual health services in New South Wales were free. It was also common for participants to experience a degree of nervousness or anxiety when attending a STI checkup for the first time, particularly for those with limited or no prior history of HIV or STI screening. And I'm certain that that's probably a common experience for many Australian-born people as well. But for some participants, feelings of nervousness and anxiety were compounded by previous negative experiences of sexual healthcare in their home countries. One participant who grew up in a country in which same-sex relationships were criminalised reflected on his first experience in Australia, saying, "It was an unpleasant experience because I would remember how it was back home, but it was completely different. It's so different. There's no point for me to be that cautious and distrusting of people." So for this participant, distrust of healthcare workers was almost an ingrained go-to position that had developed through his experiences in his home country, where healthcare workers were known to disclose patients' sexualities to government authorities. And another participant described this as having to overcome almost a sense of trauma. And I think these accounts are useful as they add nuance to the notion of internalised stigma and homophobia as an individual level barrier to sexual healthcare, and draw attention to distrust of medical authorities and the hiding of sexuality as almost an important protective strategy that they'd used in the past. Almost a survival strategy, I guess, in the face of criminalisation of same-sex relationship. But they also highlight the potential work that might be needed to help some migrant GBM, and even potentially Australian-born GBM from various cultural and social backgrounds, unpack some of their distrust that they might have with health authorities in Australia. And also raises questions about who is best situated to do this. Is it the healthcare workers themselves who might be seen as authorities, or others within their peer networks? As I'm sure won't be a surprise to most people on this call, participants identified structural barriers to seeking sexual healthcare. And so in the interest of time, I won't spend too long on these, but I think it's important to keep raising these. One participant was living with HIV, and he arrived here with his family. He was in a heterosexual relationship with children, and him and his family arrived just prior to COVID. And due to Australia's restrictions on migration for people living with HIV, this participant had initially planned on travelling to Southeast Asia for HIV treatment and care every 6 months. And he was concerned that if he were to seek out care here, his HIV status would automatically be reported to immigration authorities, and him and his family would be deported. So he actually ultimately connected with a clinic in Australia, but only because of COVID-19 border closures and the fact that he would have been unable to return to Australia. And I think we'd probably all agree that another pandemic is not a sustainable way to connect people living with HIV to care. In terms of PrEP, Medicare ineligibility and limited income were really the only reasons cited as a barrier to access. Self-importation, which enables PrEP users to import generic medications at a significantly reduced cost, did facilitate access for some, although there were some participants for whom the interview was actually the first time they'd also heard of this as an option. And I don't think self-importation is necessarily the solution to Medicare ineligibility, and we must keep advocating for expansion of PrEP access at, I guess, a higher policy level. But changing government policy is a much bigger and much slower process. So I think, again, there are questions about what kinds of resources might be needed in the meantime that could help guide people through the process of self-importation, which isn't always an easy and straightforward process. But I think there are also questions around what resources might be developed for clinicians that can encourage and help them to guide potential PrEP users through this process. So I feel like I've thrown a huge amount of information at you, so apologies. So I'll just conclude with some thoughts of some of the participants about what they felt would have helped connect with sexual health services, or at least made the process a bit easier. Probably the most common suggestion was walkthrough videos or resources explaining the testing process from start to finish. And I know that some clinics already have these, but it was felt that it was really important for these videos to also be done by others who also had or shared that migration experience. Some participants, as I mentioned earlier, were also initially unaware that publicly funded sexual health clinics were free. And so emphasising that there was no cost involved for testing, alongside the confidential nature of these clinics, was crucially important in promotion campaigns. And I think the diversity of ways in which participants discovered sexual health services speaks to the need for both very general and quite targeted campaigns and programs, which is a huge challenge given sexual health clinics, LGBTQ plus and HIV organisations are often working in a context of significant funding constraints. And it was also beyond the scope of this project to delve into this too far, but I just, as a final thought, wanted to reflect on perhaps how the interplay of stigma associated with HIV and STIs, sexual health, LGBTQ plus identities, and in today's political climate, increasingly stigma of migrant populations, how these different stigmas might intersect and affect decisions around health policies and decisions around where and how funding is allocated. So I'll leave it there just to acknowledge our participants who were really generous in sharing their time and experiences for this project, our funders and partner organisations. Huge thanks to my colleagues Ben Babington, Curtis Chan and Andrew Gorlick, who helped guide and do a lot of this analysis. And also just to acknowledge the informal input and conversations I've had with Sajid Kumar, Bernard Saliba, Mo Hamoud, Stephen Philpott and Anthony KJ Smith. And those conversations have also really helped push my thinking in this project, for this project. So I will leave it there and stop sharing.
Great, thank you for that, Nathaniel. That was, you're right, you have covered an enormous field of issues there, and I'm sure people will have questions. For people who joined a little late, where we're going now is we've got 2 respondents, and after those 2 respondents, we will have a chance for questions from the audience. So form your questions now, and we should have time for them. So we have a respondent from a community-based organisation and a respondent from the healthcare system to give us 2 different perspectives. Our first respondent is Locke Nguyen, whose pronouns are they, them. Locke is team leader for multicultural engagement and Greater Western Sydney at ACON. Over to you, Locke.
Thanks, Andrew. I'll just share my screen. Oh, it says that I'm disabled from sharing screen. Do you know if I could have that access?
Is that something Carly, are you able to help Locke with that?
I've just made Locke a co-host. I'm not sure if that will fix things.
Oh, that might fix it. Oh, great. I can do it now.
Fantastic. Thanks, Locke.
Thank you. Can you all see that okay?
Yes.
Yes, we can.
Great. So thanks, everyone. I'd like to begin by acknowledging the traditional owners and custodians of the lands we're meeting on today. In my case, that's Gadigal land. I pay my respects to elders past and present and extend my respects to Aboriginal and Torres Strait Islander peoples joining us here today. In the context of today's session being on newly arrived GBQ MSM in Australia, it's also important for me to acknowledge that Aboriginal and Torres Strait Islander peoples have existed here for over 60,000 years. And through ongoing colonization, all of us non-Indigenous people here today are newly arrived on these lands when compared to this history. And this always was, always will be Aboriginal land. So my name is Locke Nguyen, my pronouns are they, them, and I work at ACON as a team leader for multicultural engagement in Greater Western Sydney. For my presentation today, we'll be responding to Nathan's findings by discussing how the sector can challenge structural racism in New South Wales HIV peer response for newly arrived GBQ MSM and the benefits that this has on increasing social networks and connecting newly arrived GBQ MSM to sexual health care, particularly those in Greater Western Sydney. I will provide some context to Greater Western Sydney in my presentation, as well as its communities and HIV experiences. I'll then discuss the history of the HIV sector's peer response and its legacy of whiteness within the work that we do. Then I'll discuss the ways in which the HIV LGBTQ+ organizations can challenge structural racism and white approaches to increase social connections for newly arrived GBQ MSM and linking them to the healthcare that they need. So to provide a quick snapshot, Greater Western Sydney is home to 2.6 million people. That's half of Sydney's population and almost a third of the entire state's population. So this isn't a small community that we're working with. Greater Western Sydney is also highly culturally diverse, with over a third of its residents being born overseas. Australia is now also seeing its highest migration rates at the moment, where we'll see many of these communities settle in Greater Western Sydney, which means that we have to, as a sector, be proactive in responding to this movement. In terms of HIV notifications, as we've seen the successes in decreasing transmissions among Australian-born GBQ-MSM, especially those in the inner city regions, we have not been equally effective in reducing these rates in Greater Western Sydney, where we are now seeing the region make up 30% of all HIV notifications in the state, many of whom are overseas-born. So when thinking about newly arrived GBQ-MSM's connections to sexual health care, we as a sector need to reflect on why these disparities exist and take a health equity approach to challenge the impacts of structural racism and white approaches in our work, which have led to these health disparities. So for the last 40 years, our HIV response has been successful in relying on peer connections to increase HIV health outcomes for GBQ men and provide the social protective factors that come with that. From our HIV response, we knew early on through the GPA and MIPA principles that HIV organizations, programs, and policies need to be driven by the communities affected by HIV. However, these peer responses have historically been led by white gay men and typically those who reside in the inner city regions. And although this work has been highly important and has led to many successes in moving towards the virtual elimination of HIV transmissions, it's important to note the limitations and the gaps that have meant that multicultural and migrant voices have been excluded from co-leading our responses for these last 4 decades. I also wanted to provide this quote here from the Psychic Life of Racism in Gay Communities, saying, "Gay organizations around the world have inherited what we might consider a history of whiteness, a way of orienting themselves that is maintained through the repetition of decisions made over time, which shapes the surface of institutional spaces. We must reflect on how white ways of working and organizational racism within our organizations over these last 40 years have left behind multicultural and migrant communities, especially those in Greater Western Sydney." So, how does this all link to newly arrived GBQ-MSM and their connections to sexual health services? Newly arrived GBQ-MSM need to see themselves represented in peer spaces. Nathan's findings highlighted that the more socially connected newly arrived GBQ-MSM are in Australia, the more likely they are to be linked to community groups and sexual networks who would then link them to healthcare services. However, when we look at the work that has been delivered in our sector over the last 40 years, little has been done to create culturally tailored LGBTQ+ peer spaces, especially in Greater Western Sydney. I wanted to emphasize this quote that was included in the presentation earlier from a research participant and emphasize that line that they mentioned, which is, "It's just about trusting someone that is like you." For multicultural and migrant communities, trust is centered around being able to see people who look like you in the health services that are provided to us and our peer spaces. This signals to newly arrived GBQ-MSM that they are in safe spaces where they're able to talk about the sex they're having, their sexual health, and identities with people who understand their experiences of culture, migration, language, family, in a way that also aligns with the sexual cultures and norms in the way that Nathan described and that's importance in connecting people to care. Our sector also knew this early on when utilizing a peer approach because we knew that gay bi queer men would feel safer and less stigmatized to talk about sex and sexual health with other gay bi queer men, not the doctors, not the health professionals who wouldn't understand their identities or the types of sex they're having. So these concepts also apply here. To address today's HIV response, we must apply the same thinking, but with the added layers of anti-racism and cultural safety within our peer responses. Structurally, there's a need for us to then invest in building and upskilling peer networks from multicultural and migrant LGBTQ+ and GBQ-MSM, especially in Greater Western Sydney, who are equipped to talk about HIV and sexual health with their communities in a way that's relevant to culture, being a person of color, or having to navigate health systems as a migrant without Medicare. Within sexual health organizations and healthcare settings, we must also invest in recruiting and retaining staff who are LGBTQ+ people from multicultural and migrant backgrounds, who community can then see themselves in and trust enough to return and access our services. And trust me, this strategy is much more highly effective in reaching newly arrived GBQ-MSM than simply running cultural safety trainings and cultural competency trainings for staff who aren't from these backgrounds. My next point is around how do we define community connectedness and who defines it? When discussing the experiences of newly arrived GBQ MSM, our sector often defines non-community connectedness as those who are not connected to other LGBTQ+ people, groups, and organizations. However, Nathan's findings revealed that although some newly arrived GBQ MSM may not be engaged in LGBTQ+ spaces, they may still be connected to other communities, clubs, and organizations. And as queer people of color, we often sit at different intersections and have to negotiate which parts of ourselves we're willing to give up to find connection. For example, giving up your queerness to be part of a culturally safe space, or giving up our culture and language to be part of white LGBTQ+ spaces. And just on a personal note, for myself and my queer POC friends, we often find that we actually gain more of a sense of belonging in spaces that are dedicated to people of color, which are also LGBTQ+ inclusive, than LGBTQ specific spaces themselves. And often this is because we find solidarity through experiences of racism much more powerful than finding solidarity through experiences of homophobia and transphobia when we live in a white Australia where LGBTQ+ spaces have not necessarily been historically been designed for us and often are the sites of where racism occurs. To respond to this, HIV and LGBTQ+ organizations must develop stronger partnerships with community groups, organizations, and services who work with and are trusted by multicultural communities, newly arrived migrants, and refugees. And this may include creating mutually beneficial partnerships with multicultural and migrant organizations, creating programs where community can talk about their priority issues. So often experiences around racism and migration might be more of a priority for community members than talking about their sexual health. So how do we find ways to weave sexual health content through those discussions? Other ways are including upskilling staff in multicultural and migrant services on LGBTQ+, HIV, and sexual health services, which they can then connect and refer newly arrived people to. And that last point I've got here, which is around sharing our resources with under-resourced groups who are in a better position to understand the needs of the communities we're trying to reach. This is really important because even if a community is not seeing themselves in our spaces and services, how can we still achieve our goals by investing into spaces where they do see themselves in? And I have done a few presentations in the past about Westball, FlagCom, and our work with community groups like Tricone and ANTRA, but I won't go through that today here. The final point I'd like to make is around investing in work that LGBTQ+ allyship networks among multicultural and migrant communities in Greater Western Sydney, which responds to Nathan's points around the need to consider networks beyond LGBTQ+ communities. During the marriage equality vote, we saw a majority of the no votes coming from Western Sydney electorates. However, that is not to say that multicultural and migrant communities living in Western Sydney are the problem. LGBTQ orgs must reflect on how white and inner city-centric approaches have left multicultural and migrant communities behind in our advocacy. When you look at the ways LGBTQ+ communities and issues are accepted and talked about in mainstream inner city spaces, this didn't happen overnight for us, right? Many of us would have seen this progression and change happen over decades, and this was a testament to our successes as a sector and a community. However, there's a need for us to then target Western Sydney and create campaigns and initiatives that advocate for LGBT communities, which also connect to those experiences of what it means to come from a multicultural or migrant family. Research shows that LGBTQ people from multicultural backgrounds are less likely to be accepted by their families based on their queerness. However, research also reveals that multicultural LGBT people rely on their families for support around their cultural identities. And when this support is also provided to their LGBTQ identities, it has highly beneficial impacts on their long-term health and well-being. By investing in creating culturally specific allyship networks beyond LGBT communities, we are able to continue destigmatizing LGBT issues in the community, which creates a safe environment for newly arrived GBQ, MSM, and LGBT people to confidently talk about their identities, sexual health, and access to sexual health care. It's also highly important for us to avoid using white approaches when we conduct this advocacy, as this can create more harms for multicultural and migrant communities in Western Sydney, which we did see through the Belfield protests that happened earlier this year. So in summary, for my final points, I want to highlight these key points from my presentation. HIV and LGBTQ+ orgs must reflect and challenge historically white and inner city approaches to our work. Our response has been highly successful through our work with peers. However, we must continually invest in recruiting and retaining multicultural and migrant staff, volunteers, and peers who are newly arrived GBQ MSM and who communities see themselves in and trust. We must invest in partnerships with community groups and services that newly arrived GBQ MSM see themselves in, and this may not necessarily be LGBTQ plus specific spaces. And my last point is around developing LGBTQ allyship campaigns and initiatives that bring multicultural and migrant communities in Western Sydney along with us. Thanks everyone for listening to my presentation.
Thank you very much, Locke. And if you could stop sharing your screen, that would be terrific. I think you certainly laid out a number of challenges for us there, not the least of which is to really reconceptualize what we're talking about when we talk about community connectedness and allyship, among a number of other issues. So our next respondent, before we invite all of your questions, is Dr. Rachel Burden. Rachel is a staff specialist in sexual health medicine at Sydney Local Health District. Rachel, do you have a presentation?
I don't have a presentation.
That's good, it makes it easier. Thank you.
Hopefully it's not just a stream of consciousness, but I have tried to kind of group things into sort of themes that I picked up from both of the presentations. So thanks for inviting me. And thanks, Nathan and Locke, they were fantastic presentations. And I think, you know, as a clinician who's been working in this space for a long time, you know, you always realise it's always very humbling to kind of realise what you don't necessarily know and think about on a day-to-day basis. So thanks for that. I also picked up on both of your themes about trusting someone who looks like you. I'm not sure many of my clients would really say that about me as an older white woman, but hopefully our workspaces do offer that more than I do. And I just want to make the disclaimer, as I say, that I am not necessarily from community, but I have been working in this space alongside clients for a long time. And I definitely want to thank all of my patients who've taught me so much and all of the clinicians I've worked alongside in this space too. So I've kind of roughly grouped themes into just from, you know, what we see here at RPA Sexual Health, but also what I've seen as a S100 prescriber in a high caseload practice. So I think the main themes being trust and distrust in government and health services. Secondly, vulnerability and connection that we see amongst our gay and bisexual male clients that here, and then just looking at some of the challenges and what we try to do to mitigate them and maybe what we could all do a little bit better. So definitely just, you know, picking up on the theme of trust and distrust, it's definitely something that we really, you know, see as a big barrier to people accessing services here. I think a lot of our clients, depending on where they come from services where, or come from countries where both government services and particularly healthcare services aren't necessarily confidential. They're not always perceived as offering high quality care. There's often a perception that, you know, you go around the corner to private care, or you pay extra, or you kind of go through the back door to kind of buy confidentiality and buy better quality services. And so that just some of that kind of health seeking behaviour can be quite different, but people just don't necessarily come to our service thinking that what they tell us is confidential and that we're not going to, you know, feed some of the clinical or social information back to their governments, their universities, their families, their communities. And that's something that we have to work really quite hard on, harder in some different client groups than others. Obviously, people who are refugees or who've come from conflict situations, that's particularly difficult. People who've suffered a lot of trauma, discrimination and self-discrimination about being gay or bisexual are particularly difficult to engage. And as you say, a lot of that's really ingrained, so that it's difficult for people to get to our services in the first place. And then even more difficult at times to stay in those services, particularly where there might be an HIV diagnosis. And that's definitely a lot of what we see. What we try and do to sort of mitigate some of that is just spend a lot of time debunking some of those kind of perceptions, talking to people about the fact that, you know, we're not linked electronically to other systems where information can be passed on. People don't obviously, well, a lot of people are Medicare ineligible, but they don't need to use any Medicare or ID, and that they are able to use pseudonyms as a way of protecting their confidentiality. So those are some of the things that we're kind of able to do. In preparing for this, I was talking to our senior counsellor, Loretta Healy, who probably has a lot of experience, more experience than myself on this. But one of the themes we sort of talked about was, or she talked about, was just some of the vulnerability that comes with being a newly arrived gay or bisexual man, and how often they, particularly the younger people, have quite limited experience with being open and gay or bi or having sex with men. They're used to living in a more closed, secretive environment, and how at first it can be very exciting and you know, to be in Australia where you can be out and able to actually express your sexuality, but that also can be very overwhelming to people, and we see that that people can be quite overwhelmed at times, but also very vulnerable and taken advantage of. And it can be difficult to negotiate sex when you maybe don't speak the English as your first language, and you aren't used to kind of the rules of behaviour that, you know, like Australian-born GBM might, you know, just know and have it be a little bit more ingrained. And when I've done a few presentations in the last year with Brent Clifton from NAPWA, and one of the things that he comments on, and that I feel like we do see in the clinical sense, is that so drug use and sexualized drug use in gay and bisexual men from overseas can really be quite problematic and prevalent, and is men that may not have necessarily used drugs before or used drugs with sex, possibly related to social anxiety and sort of negotiating some of these norms around sexual behaviour, feelings of vulnerability and anxiety, and how he sort of and his network see that can be quite problematic in newly arrived gay and bisexual men. So I'm sure there might be some people who have some experience who would like to kind of comment on that, but that is definitely something that we experience here at RPA Sexual Health. I think the other interesting thing, Locke, that you commented on was that kind of issue about family and cultural identity as being, you know, so necessarily, I think, particularly for people's mental health and the way they feel like they sort of fit into the world. And, you know, again, Loretta and I were discussing before this how that sort of sense of being a young, new gay bisexual man in Sydney and being out and amongst it can be a bit of a conflict with, you know, that sense of family and belonging and attending to family crises and keeping in with cultural norms, and some of that sort of perceived behaviour around, you know, what family will imagine if they disclose either sexuality, particularly around HIV status. And that's something we really see can be, you know, problematic, particularly around people who are living with HIV and facing some issues with their ongoing care. So again, so just moving on to some of the challenges, I think Medicare eligibility is obviously a big structural one. I feel like can particularly be one around PrEP. We do try and manage that by we do provide prep scripts, and I think a lot of the publicly funded sexual health clinics do for our Medicare ineligible population. So that takes the financial disincentive from going to a GP and paying for all the testing away. And there are some pretty reasonably priced options online through websites like Prep Access Now. And now I believe that even at like Chemist Warehouse, we're able to get a private prep script for around $30 a month. So, but again, I definitely agree with educating the wider community about how that can happen. The clinicians needs to happen. I would love to see the UK model where prep is free for everybody. I think that that's something we would definitely need to work towards for the future. It seems like a bit of a no-brainer to me. Other challenges that we face, I think working with interpreters can be a little tricky at times. A lot of our consultations are done through interpreters. There can be a lot of fear around that. People feel like they might know them from community. There can be a lot that's lost in translation. Some interpreters are better with kind of managing some of the nuances of our conversations than others, and that can be a little bit of a barrier, I think, and really impact on the quality of a consultation, and also in building trust. I find it really hard to build trust with interpreters. It's a really tricky one. Again, we really rely heavily on services like multicultural and some of the other groups that you've alluded to, particularly with our newly diagnosed clients with HIV. But we do see a lot of them do have a lot of fears around confidentiality and feeling like the peers come from their community and they might not want to disclose to them. And even as much as we just, say to them, these peers are bound by confidentiality agreements, that can be quite hard to get people into those services. Once they access them, they absolutely love them. So I think that kind of generally works really well. The legal and structural issues is, again, something we are always battling against. People are always very nervous about how any STI, particularly HIV, is going to impact on their permanent residency application and status. Difficulties with we might be able to manage sexual health issues in our sexual health clinic, but if people have other medical issues that can impact mental health, other medical things, it's really hard to get people into care that's affordable and accessible. So what can we do? What do we do currently to mitigate some of these things? I think in the publicly funded sexual health clinic space, we are very lucky to have fantastic social workers and who can help negotiate some of the pathways like multicultural to HELC, who we use for legal support, interpreters, and there are some of the other wraparound services. I think what we possibly need to do more of is have more diversity in staff who can speak language, because we find that in our clinic, if we have, as you say, people who look like us and can speak a language of our major sort of populations from overseas, it really, really helps, both in terms of building trust, but also in communication and just general logistics. I'm interested that we do get a lot of referrals from the universities, but obviously from what you both said, that isn't really going along far enough if people are feeling like they're getting information targeted for heterosexuals and not for their own, how they identify. So we obviously need to do more in that space. I think a lot of our clients from overseas are actually attending less formal education, like some of the colleges that are teaching English and other kind of trades, and they don't always have the information for the people that attend to get them to our services. So that's something we also kind of really need to think about as well. So that's probably where all I've got to. I'll be very interested to hear what everyone else in the audience. I'm sure there's some very experienced and talented people, and yeah, so thanks for inviting me.
Great, thanks, Rachel. That was really valuable, and thank you for your insights. People have been getting busy in the chat, making comments and questions, and I'll try to summarise a few of them and put them to our speakers. We unfortunately only have about 10 minutes. First question comes from Stephen Philpott, who's a researcher who's done quite a bit of work in this space, and the question is for Locke. Locke, you might have seen hopefully you've read the question, but it's a question about LGBTIQ community spaces that may not be well designed for called GBM, and what are there any examples of inclusive design, or what can these spaces do to be more inclusive?
Yeah, thanks for your question, Stephen. I think something to think about in our work is, especially in the LGBTQ HIV sector, is often, and within multicultural health sectors, I often see that the work is often divided into those two arms. It's either LGBTQ work or multicultural work. And I think when we separate the work in that way, it positions LGBTQ work to inherently go with the status quo of what it means, or what the norm is in Australia, which means that the LGBTQ work will often bring in white perspectives, white ways of working, and white understandings of what it means to be LGBTQ+. In the same way, if multicultural work doesn't engage with LGBTQ design and spaces, they will be lacking that insight as well. So in terms of building more inclusive spaces, I think it's important that when we design programs, health policies, design research projects as well, that we have people who sit at those intersections across gender, sexuality, culture, and migration experiences, to ensure that when we're talking about our communities, when we're designing questions, when we're designing policy, that our experiences are driving those decisions. As Nathan had also mentioned, it's around who's driving those decisions, right? When we also talk about sexual health, in the context of sexual health, it's also important to think about how is that talked about among newly arrived communities or among communities of color, because that will look different to white, gay, bi, queer men per se. So how does racism impact the way that we navigate accessing sexual health? How does experiences of racism in dating and hookups also impacts the ways that we make decisions around our sexual health as well? So all of those nuances will be understood when we have staff members who come from those lived experiences driving those decisions as well. Another thing to think about is I've had friends talk about how that they feel safer to attend spaces that are dedicated to people of color who are LGBTQ friendly, and they might still encounter a bit of homophobic or transphobic, I would say, ignorance than actual homophobic views, where people might not understand all of our identities. But I've found that a lot of people of color find more safety in those spaces than going into white LGBTQ spaces and encountering racism. And I think it's important for us to consider why that is the case, that we negotiate, that we're open to accepting to flack a bit of homophobia than comp racism.
Great.
I don't know if that's a bit confusing.
Thanks, Locke. That was a great answer, and we'll keep it moving just so we get a few of these questions raised. Nathaniel, a question for you from Simon Yu, who made the really interesting question about, did your research tell us anything about the timing, but how quickly people became connected to sexual health services? And because, if we could identify those triggers that led to engagement, that would obviously be really valuable for health promotion.
Yeah, it's a good question. And we did sort of try to get a sense of how soon after arriving it took for people to engage with sexual health services. And I think one of the frustrating things, maybe frustrating is not the right word, but it was frustrating in the sense that some, it was almost, the week that they arrived, and others took 6 months. So there was no real sense of kind of a common time. I remember one person arriving just before Mardi Gras who was like, oh, better go get prep because Mardi Gras is about to happen. And for others, it was sort of a few months after they arrived because, they'd had notification of the potential STI exposure. So yeah, it was a huge diversity of timing and reasons why people went. So
Great, thanks for that. And the next question comes from Dr. David Templeton. Dave, it looks like you wanted to make a comment. Do you want to unmute and make a comment? I think.
Sure, I'll even show my face, Andrew. Hello.
Right.
Well, I'm very dark actually today. I don't know why. No, it's just about the immigration. Nat, thanks for a really great presentation, really good insights. And obviously, I work with Rachel, so you know, she's given the background of what our experiences are here at the clinic. The barrier it sounded to me like you were alluding to that there are significant barriers to immigration for people who come over with HIV. I just wanted to, I guess, provide our experience, and our experience at the clinic is that HALC do an amazing job, and basically I cannot tell you the last time, or if I even remember, any of our overseas born applying for permanent residency with HIV who helped them get across the post. They all ended up getting permanent residency, and that includes you know, Asian gay men, people from Africa, heterosexuals, all gender identities. So yeah, it's interesting because one of the issues that's a bit kind of problematic for us is that you don't require an HIV test to come in on a student visa, and I understand that would, you know, there'd be two sides to that story, because probably some advocates would say, well, we shouldn't do that because, you know, they shouldn't need that. But then the other side of the coin is that often that they won't have been tested for HIV, and if they're not engaged quickly with sexual health clinics, then they actually, you know, can be quite immunosuppressed by the time that they finally are diagnosed.
Thanks for that, David. And Nathaniel, did you have any response to that? I suppose part of the issue is that even if the truth is that with legal challenge, people can chat, that can stay, that the perception and the reality is that there is still, you know, legislation in place which can deny these people under some circumstances. So it's still a pretty tough road for them to go through, I would have thought, David.
Yeah, and this particular participant as well, he'd been told about help from the clinic he was going to, but he didn't seem to feel that even they'd be able to help him, even after the clinic had encouraged him a lot, and even after I'd encouraged him a lot, that they did really good work. So, but yeah, I think it was that initial perception that was the barrier for him for initially going for care.
Sure, thanks, Nat.
Right. Okay, it's about 2 minutes to the hour. Any final comments from any of the speakers been wanting to make a burning comment that they really wanted to say before we sign off for the day? If not, just a huge thank you to Nathaniel, Rachel and Locke for their presentations. Today's session has been really popular, with nearly 100 people turning up and over 200 registrants. So it really does highlight the real interest in the sector there is at the moment about really coming to grips with this and taking action on it. So thank you to all our presenters, and thank you to everybody who's joined us today. Bye for now.